Karin Hatzold will make her presentation.
Thank you very much for the invitation. I would like to thank the organizers as well to put BMC on the agenda. I think thanks to Catherine that this is on the agenda, I think. I will go back a little bit and speak about the public health intervention male circumcision and also give you an overview of the male circumcision program in Zimbabwe. I'm going to speak a little bit about the devices because after the studies we also introduced the device in routine service delivery, and I will speak about the active and passive surveillance phase of the prepex device here in Zimbabwe and our experience with this. Next slide. Sorry, I have to click. Okay, just a quick overview of the milestones of the Bmc program here in Zimbabwe. So it started very early. The Ministry of Health and the National AIDS Council convened a consultative meeting actually after the results of the randomized controlled trials came out from South Africa, Uganda and Kenya. And this consultative meeting concluded that male circumcision should be added on as an important HIV prevention intervention into the package of combination HIV prevention in Zimbabwe. Did mathematical modeling to decide which age group to target for male circumcision and concluded that the age group 13 to 29, so young adolescents and up to 29 would be the priority group of targeting for this intervention because of its impact on HIV incidence reduction. What we have to say as well is that Zimbabwe is probably the country where male circumcision has most of the impact, is very effective in preventing HIV infections. So based on mathematical modeling, we know that if we have male circumcision to reach 80% of this target population of 30 to 29 by 2017, we would be able to reduce HIV prevalence to 4.4% instead of 7.3% by 2020, and we would avert 220,000 new HIV infections in Zimbabwe. Why is that so? Because male circumcision is not common in Zimbabwe. Male circumcision prevalence is only about 10% and varies by region. It's between 5% and 18% by province. And we have a relatively high HIV prevalence here in Zimbabwe. So male circumcision is a very effective HIV prevention intervention. So you can see on the graph that we have the annual targets, and we're starting in 2009 with a pilot phase. 2000 male circumcision was the target. We overachieved this. And we had, in 2012, a tremendous increase in the number of male circumcisions was conducted because more donor funding was available for the scale-up. Nevertheless, male circumcision is not necessarily a very easy to implement program, and in terms of the public health impact, obviously it has a public health impact, but it's not a very easy to sell intervention. So what we have faced, and I'm giving you a bit of an overview of the supply and the demand side of male circumcision, there needs to be a constant supply and demand balance. If you have more supply, that means more available of services and not enough demand for the services, then you have people are not using the services. On the other hand, when you're creating demand and the availability of services is not there, you have also an imbalance. So it is always important to have a balance between demand and supply. Where we currently are with male circumcision is that we're probably more on the balance of supply, or more supply than we have demand. In the beginning, we had probably more supply than we had demand, and we had created them to create demand. But I think we are currently now more in that phase where we need to have more demand for male circumcision. So quickly about the supply side of male circumcision. We have in Zimbabwe, as you know, implemented the models of volumes and efficiency to improve efficiency of male circumcision service delivery. There are components that are on the right-hand side that guide these efficiency models of service delivery. The clinical technique that has been used has been a standardized male circumcision procedure that had been used, in which everybody had been trained. We used a team of providers instead of only one provider, and we also provided the male circumcision services outside of theatre, outside of the surgical environment, in clinics without going into surgery. The logistics, bundling instruments and using disposable instrument sets are very important as well for efficiency. Instead of having to re-sterilize instruments, if you have to have a fast throughput of clients, it is extremely important. So So improving efficiency of service delivery was very efficient, and we could actually reach about 10 male circumcisions per hour to be conducted by a team of 1 doctor and 3 nurses, including the entire surgery. So for surgery, costing about 12 minutes per male circumcision. We also in Zimbabwe introduced this boarding house school of nurses, so it's not doctors conducting the male circumcision, but the nurses conduct male circumcision. That applies for the surgical procedure as well as for prepegs. Obviously, quality assurance is extremely important. Fortunately, our adverse events rate with male circumcision is under 3%, and this is actually lower than what we had seen in the trial studies. We have a very efficient training program that is decentralized at the district level, provincial level, and we have a very efficient supply chain management system to have all these commodities at the site whenever they are needed. Obviously, there are challenges as well, because we need different supplies for different methods. We're using 2 methods currently, the forceps guided method as well as the dual slit method. And for the device, it will be even more complicated with different device sizes that we have. Currently, we have 5 sizes, but we're going towards 10 sizes. Because we also included smaller sizes for the adolescents. So the service delivery models are quite important as well to have efficient male circumcision services there. We have 3 different main male circumcision service delivery models. Services are provided at fixed sites or healthcare facilities or at dedicated sites that are only providing male circumcision. What we have to say is that male circumcision is a vertical program. It's a bit like a vaccination program where you have to go very fast and have to be very efficient to circumcising many people in a short period of time. So people have to be dedicated, healthcare providers have to be dedicated to provide these services. They have to be available all the time. So even if we're seeing it's an integrated service delivery model, services are co-located. So there is a unit for male circumcision even at the hospital level. So services are provided in urban areas and in rural areas as well at fixed sites, healthcare facilities mainly, and we're going down to the district level, even to the clinic level to provide the services. And also services are provided on outreach. On the right-hand side, you can see the different costs, and that is very important. Obviously, efficiency is also coming with cost, and now in reducing costs for HIV prevention, we also see that we have really to look at what is the most efficient way of reaching high numbers of clients. And you can see here, there are variations. Cost per male circumcision is about $100. And you can see that some of the service delivery models, for example, urban dedicated sites with higher number of throughputs, mainly driven by the denominator of male circumcisions conducted, is probably very cost effective as compared, for example, to urban outreach. Just quickly, we're always struggling with reaching the right age group. And this shows you what we have done, what we've done up to 2013. So the cumulative number of people being circumcised, and by age group, on the left-hand side you can see the age group of the clients that were circumcised. You can see the highest number of people who were circumcised in the age group 15 to 19 and 20 to 24, or 10 to 14 and 15 to 19. But when you put this percentage or the number of people reached towards the pyramid, the population pyramid, you can also see that actually equal segments of the population has been reached. Because obviously in the general population, in the pyramid, we have much higher numbers of the 15 to 19, of 10 to 14 years old. Nevertheless, as the program progressed, we have seen that since the beginning of the program, where we reached mainly actually people from the age group 20 to 29, and about 35% were between 10 and 19. We now see in 2014 a complete reversion of this. So demand creation for male circumcision, especially amongst younger age groups, adolescents, from the age group 10 to 14 and 15 to 19 has been much easier than for adult or over 20 years old. And that is currently the problem that we see. We have reached high coverage in these age groups, but we have been not very successful in reaching our older age groups. Quickly about the demand creation and the challenges. As I said, male circumcision is really a social marketing challenge by excellence. It is targeting men who are normally not going to healthcare facilities, who are shying away from many services, who have not very good health-seeking behavior. We're offering them an intervention that is potentially painful, male circumcision, a surgical procedure with a benefit of HIV prevention that is long-term. Yeah? So it's quite difficult to sell male circumcision to men and to have high uptake. You can see this here is the theory of adoption, that with the early adopters starting to take up the service of a new product, and then the latest would be the legates. I think I would place Zimbabwe at the early majority. We are not yet at the tipping point. We had about 32% of people reached with male circumcision of this population that we want to reach. So the major barriers, and that is Zimbabwe, but also probably can be extrapolated to other countries, is obviously that this is based on qualitative and quantitative studies that we conducted in Zimbabwe in several years. Pain is the major fear factor. Surgical procedure, obviously it's done under local anesthesia, and we have to see with the devices why the pain came up. The device is core, the application and removal is done without local anesthesia. I'll speak a little bit more about this when I speak about the device experience. Fear of the operation, fear of the HIV test, even though that HIV testing is not mandatory, it is perceived by people that you have to take up HIV testing before you get to circumcise. The long abstinence periods of 6 weeks in which you should not have any sexual intercourse is preventing people from taking up male circumcision. You also know that people are starting early sexual activity. Actually, 30% of our clients are starting before the 6 weeks abstinence period has been finalized. And obviously cultural and religious factors. And the motivators are mainly what we're already promoting in our communication campaigns: HIV and STI prevention, hygiene benefits, but also sexual performance. People have the impression, and we leaving them to believe this, that male circumcision might increase sexual performance. Also people perceive it appealing to women, especially for the older age group, and being part of the group or being an example for the community is also one of these reasons that are mentioned mainly by older men. We did a study to identify the barriers and motivators again, and also to really inform our communication campaigns. And in these results that were published in the PLUS supplement, we saw that there were differences in motivators and barriers amongst different age groups. So a shoe fits not every foot. And we saw that there were differences in motivators for younger age groups as for older age groups. Hygiene, for example, played much more an important role in older age groups than HIV prevention. Also, peer support and being influenced by peers was very predominant in the younger age group as compared to the older age group. And sexual pleasure, or what the partner thinks about male circumcision, was very important for older age groups. Also, the emphasis on non-HIV benefits, that prevention benefits, was seen as a really very important factor. So not pronouncing HIV prevention, male circumcision, and combining this was very important for people to make sure that the partner buys into male circumcision. Otherwise, it introduces a mistrust in clients who undergo male circumcision. So on the left-hand side, you see the factors that were significant different in those who have adopted and not adopted male circumcision. The perceived availability of services, the social support that they received, and the self-efficacy were a major factor of accepting male circumcision. This is the campaign that we have developed. So we use celebrities to increase social support for the intervention, and we are using them as role models. So they themselves have undergone male circumcision and pronouncing for the male circumcision, pronouncing themselves for the male circumcision. We have also used parliamentarians to increase acceptance of male circumcision, and this was quite effective. We, again, don't promoting HIV, male circumcision as an HIV benefit, but more for personal hygiene, reducing the risk of the partner and cervical cancer, and also to make it a smart intervention, the Pinamo Smart campaign. And that was very successful. Nevertheless, we still have demand creating challenges, and we did a study with a marketing firm, Ipsos, who looked at other barriers to male circumcision that we have addressed now in our communication campaign. I will not dwell too much on this because I don't have a lot of time. Just want to quickly speak about the Bmc device again, the prefix device. So, to have the ideal device that would increase uptake of male circumcision, that would make perhaps this procedure safer, that might be less costly, and that would also increase efficiency in terms of human resources that are used and also materials, would be probably really good to have. And this is why we looked at these studies with that regard on the PPEX device as one new intervention that could probably increase male circumcision uptake and also efficiency of service delivery. So what we have done in the active and passive surveillance, and PSI supported the studies, by the way, through funding that were presented by Professor Chimanga. We supported these studies were funded by the Bill and Melinda Gates Foundation. We conducted the active and passive surveillance phase of PPEX, and we've currently about 6,000 PPEX device applications and removals and circumcisions. What we have seen is so far that there are still bottlenecks. Demand creation instead of problem uptake has not been as high as we anticipated. There's huge issues with training because you have to training to conduct the PPEX device, and the training has not really scaled up as fast as it should have been. And also there is really important to strategize. Where do we use PPEX? There might be cannibalization over the surgical procedures, and you offering both. This is the, in the active surveillance phase, the uptake of PPEX as compared to surgery. And as you can see, it varies by region. In Bulawayo, with the highest 65%, and in the lower, in Spearhouse and Harare, in Motivators, it was about 30%. So uptake of PPEX, when it's offered as an alternative to surgery, has not created actually so much demand. Nevertheless, we have to say that demand creation has been a little bit behind as well. We looked specifically also on acceptability, and what came really clearly out is that pain perceived and that pain experienced with a PPEX device is a huge demotivator for people to come forward, and it goes around in the communities as we had started it. We have addressed this now in providing MPH cream that we are applying at removal of the device, and this has tremendously reduced the pain levels at removal of the device. Odor was another issue that prevented people from taking up PPEX. And I think we are also having addressed some of these issues in terms of odor and have prescribed hygiene measurements that people have to undergo when they have the PPEX device applied. So just very quickly, looking at the service delivery models that we would like to use for PPEX, and that is an unpublished study, where we think PPEX service delivery would be making a lot of sense is where we currently cannot provide surgical procedure. So not introducing PPEX at the same level where we're providing surgical procedure, but at a level where only PPEX can be applied. So at the clinic level, at the local clinic level. And you can see also that it is probably the most cost-effective implementation model. So the way forward, we think we have to strategize in BMC scale up much more. We have to prioritize. There's not enough funding available for male circumcision scale up, and we have to look at those models that are most efficient. We have to look at geographical distribution and seeing where we have more reach, high coverage. We have to identify service delivery models that would work most efficiently. We have to look at older age groups as well, because we have reached all those youngers. We have to look at how we are introducing devices and versus the surgical procedure, and also developing additional demand creation activities and interventions that are based on research. And I think last but not least, really for the older age groups, I think also addressing structural barriers to uptake. For example, making the services more adult, male circumcision client friendly would probably also have a huge impact on uptake of male circumcision.